Okay, I think we should start. Good afternoon, everybody. Welcome. Good afternoon, everybody. Welcome to this Monday afternoon's Hematology Deep Dive. It is with great pleasure that Sanbis is hosting this event in collaboration with the Hematology Deep Dive team. We have a very special guest today, Dr. Femke Noorman, all the way from the Netherlands. But before we get to that, I just want to go through a couple of housekeeping notes. As per usual, the recordings for these sessions can be found at the bloodsa.org.za website. If we can please ask that people can add their questions and comments in the chat box. We will either answer them as we go, or at the end of the presentation, we will have Dr. Noorman respond to those. The CPD points will be automatically submitted to your HPCSA account for each attendee. This is for the South African participants. If you haven't done so, please make sure that you have registered or that you are attending with your own personalized Zoom account. Otherwise, you won't be getting your CPD points. Very important. And then we also really appreciate your honest feedback. I think the Heme Deep Dive is a really great collaboration and a wonderful initiative. Primary aim is to make sure that we ensure the preparation of the various registrars, but more importantly, I think just wanting to share current information and best practice. So if there is, please, we ask for honest feedback on how the presentations can be made better, what are the topics that you would like to hear on, etc. So it is anonymous, and so you need to worry about the fact that if it's some negative feedback, that there will be anybody that the feelings will be heard. I'm just going to stop my video because I think we've just got into load shedding, so that's not too great in terms of bandwidth. Yeah. So a reminder also that the 14th International Donor Registry Conference in collaboration with the World Marrow Donor Association will be taking place next year in Cape Town. So we really would appreciate it if people can participate. And then importantly, just in about 10 days or so to go for the 15th annual Heme-Onc Symposium. These are always really great meetings in a very nice setting, I must say. The Lord Charles Hotel is always a lovely place to attend. So for anybody who is interested, I think registration is still open. I think then, just get to the next slide. My apologies. So just a reminder of the management team for our Heme Deep Dive, Professor Estelle Verburg with the support of Gerdien and Melanie. So thank you very much to the team for always making these such interesting events. And then I think we can go on to our program for this afternoon. And today we will be having Dr. Femke Noorman, as I indicated, talk to us on the use of frozen platelets, although they do use many other frozen blood products. Specifically, I think she's come to speak to us about the frozen platelet program. Dr. Noorman is a very interesting woman who heads up the quality and research, head of quality research and development at the Military Blood Bank at the Central Military Hospital in Utrecht. And she completed her PhD in Leiden University. I'm not going to read through all of that. I think you can all do that on your own time. But suffice to say that when it comes to frozen blood products, and in particular the use of frozen platelets, Dr. Noorman is truly one of the international experts in this field. So Femke, with that, I'm going to hand over to you.
Let's see if everything works. Yes, and then where's the screen to share? Ah, here. Wait. So can you see my slides and can you hear me?
We can hear you, see you, and see your slides.
Great. So I'm very grateful to be here and very nice. You are very nice people and it has been a great experience so far. So I hope that with these slides I can inform you more about our work. And let's start. So, frozen for combat. Here you see the patient that had the most transfusions in Afghanistan. He received 120 frozen blood products during his treatment of 48 hours before he was flown home. And afterwards, he came to the blood bank to give an interview, and it was a very big honor to speak to this guy, and also very grateful to have seen that our products have worked with him. And he's still in the news sometimes because he always wins the Invictus Games and doing every marathon he can and wins it. So by that, I want to start about our products. Even kijken, hoe gaat die verder? Ja. Why do I have a military blood supply? Well, as you imagine, in war, there's a lot of healthy people getting wounds and they're bleeding. And if you don't have blood products, they will die. Of course, you also need a surgeon to stop the bleeding, but you have to refill it. So, of course, you know that you need red cells for oxygen, plasma for osmotic pressure, and clotting, platelets for clotting. That's very simplistic because you need all of the three to do all of the three. How do we get those products in war zones? Because we are the military blood bank, we only buy blood from the civilian blood bank, we freeze them, transport them to the area, and there we thaw them for using. And it has a few advantages. And one of the most important advantages that the products can be stored for years instead of days. So platelets can be stored for 4 years at -80, and we are currently doing research to prolong this to 8 years next year. I'm confident that will work. I can show you some results that from 12-year-old platelets. Plasma we can store for 14 years and red cells for 30 years. Advantage of plasma and red cells is that after thaw you can still thaw them, keep them stored for 2 weeks at 4 degrees before transfusion. So you can ship it, thaw there a small stock for if you don't expect a lot of patients, or thaw more if you expect more patients. But platelets we always make on demand. And usually we are in touch with the helicopter team of the ambulances and we know when a patient is arriving. So we have a lot of advantages if you work with a small hospital with 1 or 2 operating rooms. Everywhere we send surgeons and a little hospital, we try to send blood products. So that's my major job. And I do the research on the side. The easy thing about the frozen blood products, as you see here, you can transport them on dry ice. -80 can be supported by dry ice. And if you have a good box, you can ship them with a lot of dry ice. You can ship them for 10 days around the world. And here you see an example of that big box. In this big box, 96 units are fitting. In the area, we have the equipment to thaw the products. So we need a water bath, and sterile connection vise and a sealer. For the platelets and the plasma, for the plasma you only need a water bath, but for the red cells we need a deglycerylizing equipment, and this is the ACP215 from Haemonetics. It's a rebuilt apheresis machine that is able to do the cell washing, and that is because red cells have glycerol as an antifreeze. I will focus on the platelets, so skip the red cells. Of course, we also need a -80 freezer and used CO2 backup and an infrared thermometer to monitor the temperature of the products. Will I tell you a little bit of it later. Well, here's how it looks like. We have small peripheral blood banks on these smaller vessels. That's only a table with 2 machines and another table with a water bath. And the freezer is in the captain's room because there's not much space. Then we have containers we can put everywhere, also on the back of this ship. And then you have everything inside this little container that is plugged into the electricity. So we've been doing that all around the world, but not in the Netherlands, as we are not allowed to provide blood products in the Netherlands. So we ship it to Bosnia, was the first location where we used all 3 frozen blood products. We still had black and white cameras. And then Pakistan we went into for earthquake. We've been doing the Ocean Shield mission in the Indian Ocean. Iraq and Afghanistan was our major project in the past century, this century. We see some frozen red cells. How to produce the red cells? It's pretty easy. You just need the red cells. You centrifuge the supernatant off. We started with whole blood, but now we use red cells concentrates. So we centrifuge to remove the additive solution. Then we add glycerol as an antifreeze with the machine, the same machine you saw before, because this machine can add it sterilely to the product. Then we centrifuge again, remove the excess glycerol by expressing the supernatant, and then we pack the remaining packed cells in an overwrap in a box, and we put the box at the bottom of a empty -80 freezer. And after 24 hours, the products are well frozen and then put in upright freezers. In the area, there the products are moved from the freezer, put in the water bath, and then some saline, different kind of salines are used to remove the glycerol from the red cells. This is done fully automated in the machine. So there's a little bowl in there that centrifuges the supernatant away, and you end up with a product in additive solution 3. And in this storage solution, you can store them for 14 days at 4 degrees. Well, it takes some time to remove the glycerol, and we say that you can produce 5 units with each machine in 8 hours. So if we have 3 machines, then you can produce 15 units in 8 hours. That is enough to replenish the stock if things are normal. If there is a really high demand, we also ship liquid stored red cells to the area, because then there's also more transport to the hospital, and it's possible to do that. You have to remember that every transport to a military location is a danger, especially if you do it regularly, because the enemy knows that the car is coming. So the main advantage of the frozen cells is also that you can do it in a non-regular way, because you can have a stock on location. Now about the platelets. Well, they're even more simple to make. So what we have is a platelet concentrate. We use apheresis platelets, but you can also use buffy coat platelets. That the Australian Red Cross has shown that, and also New Zealand has shown that. So you can use buffy coat platelets, and we use bags of DMSO we can buy from a company that is already sterile. So we can sterilely connect a bag with DMSO. You see here the little bag, and then add it by gravity while the platelets are on a flatbed shaker. So it's added in 10 minutes. Then we connect the freezing bag. This is the standard PVC bag for 400 ml or 600 ml, whatever is available to you. Then put the product in the freezing bag, but leave the platelet bag connected, because we centrifuge, and then we express all this visible supernatant into the old bag. And then we end up with a very concentrated product in 15 ml of plasma DMSO, and then put it also in a box and on the bottom of a freezer. So we use all the same boxes for all the products, so we have easy logistics. And yeah, it's easy to put them also in the freezer. So we have things colored code, because if you have a lot of products in the freezer, you cannot see which is which if they all have the same color. So we have blue boxes for platelets, yellow boxes for plasma, and white boxes for red cells. I thought of red boxes, but it costs a lot of money, and white boxes look more clean. How do we thaw them? Well, that's the main thing to learn. If we put the products we ship to the area, there are people we have trained. So we are not doing that ourselves. We train the military that go there. So this can be doctors, pharmacists to be the boss of the blood bank, and technicians, pharmaceutical assistants, nurses to train well, for platelets. I only need half a day to teach you how to prepare for thawing. What you do is you put the product in the water bath. That takes only 5 minutes. But as we decided, it's only 15 ml and our patients need plasma anyway. We first thaw a plasma. Then after 25 minutes, we check the temperature of the unit. If it's 27 degrees, then we put the platelets in the water bath. And then after 5 to 7 minutes, both products are above 30 degrees. Then we still connect both bags, and then just by gravity add the plasma to the platelets while with one hand you are shaking the platelet bag. You reverse the bags, put it in the plasma bag again, and then you fix a label on the plasma bag and write the expiration time. We also tested if we could use cold stored plasma. And then if you do that, it only takes 15 minutes because then you can remove the plasma from the refrigerator, put them both in the water bath, and then it takes only 7 minutes, and then both products are already 30 degrees. I must tell you also, like in the US, they can also use saline to do this. So if you don't want to expose the patient to plasma, you can use saline or additive solution. But we chose to use plasma, and in fact, we only use AB plasma and O platelets, so we don't have to worry about the blood type of the patient. Well, what is the content of the product? We tried also in the field to take a sample or leave a sample in the plasma bag or the platelet bag, and then measure it for platelet count. And as you can see in the blue line, the average about 310 to the 9th platelet per unit. And the red line is 200. This is the European guideline. You see KX measured, XS measured. What does it mean? There are two different analyzers we have used in the past 20 years. And we found that when we switched to a different analyzer, we got higher platelet counts after thaw. And we thought, well, that's nice. We have a 300% increase or more than 100% recovery. Well, that is if you freeze them, measure pre-freeze with the KX and after thaw with the XS, then you overestimate the recovery because the XS is more sensitive, measures more platelets, and that's why we now end up with a better product, or at least we have higher product content. And if you see on the x-axis, this is the storage time in years. And you see that in the operational area, we used them so fast that they didn't become older than 2 years. And at that time, that was also our expiration date. And we prolonged from 2 years to 4 years in 2014. So we had some products in our freezer, we kept in the freezer, and we tested 2 years ago those old units. And you can see in picture number C, that these are giving the same results as the shorter stored products. But when we were too anxious to test our new DMSO before we used the bags of DMSO, we used bottles of DMSO. And then we had to spike it. So we switched to bags so we could do sterile connection. And then we saw that if we are too impatient, we get a lower recovery. And you start to think that your DMSO doesn't work. Yeah, we will just have to be patient and keep them in the freezer for half a year, and then you get a normal recovery. So this is just an analyzer thing. It's not a product quality thing. The platelets are probably a little bit sticky when they're frozen for a short time, and that's why you measure less. So if we just look at the European guidelines, it just says that more than 90% of the thawed products have to contain more than 210 of the 9th platelets. and the platelet recovery should be above 50%, and we easily meet those guidelines. We published our data in the last version, January of transfusion 2023. And here we also put in more detail on the DMSO and other characteristics of the platelets, which I will tell you more about tomorrow morning if you attend that meeting. Or well, where did we use the products? I already showed you nice pictures. This is just the global view. And you see that since 2001, we used about 6,500 frozen blood products in 1,061 patients. And of these patients, 361 received 1,160 thawed platelets. We also actively monitor our hemovigilance. So with every product, we send a form to the doctors. They have to fill in if they saw a transfusion reaction or not. And we only got 2 urticarial reactions reported back to us. So we are convinced it's a safe product to use. Again, this picture, because we switch now to the clinical data of how we used our blood products and especially the platelets. First, a little bit of history. Massive transfusion used to be done with red cells until the patient was bleeding to death almost, and then we would give plasma and platelets. The main emphasis was on warming, so prevent hemodilution and hypothermia and acidosis. Of course, this is still true, but already in 1999, they say maybe we should use more plasma and platelets. And what you see in this slide of this publication, you show the improvement after switching to components from whole blood. So in that time, components became more popular than whole blood, and after this century, it was not done whole blood transfusion. But nowadays, whole blood is becoming more popular. I'll get back to that. So we learned from that. Our blood bank was founded in 1939 with the draft of our military for upcoming war. And the only thing we did then was blood typing donors and trying to write down their telephone number so we could find them. A lot of change since then. Since 97, we don't have our own donors anymore, so we buy it from the blood bank and then freeze it. And in 2007, we changed our transfusion policy based on lab values. So this was our schedule. First, warm the patients, make sure that they're not colder than 35 degrees. Take a blood sample. If the hemoglobin is lower than 8, then you should use transfuse a red cell. And if your APTT or PT was very much prolonged, like 150%, then you should give plasma. And if the platelet count would be below 50, then you would start transfusing platelets. But we already gave the advice, monitor bleeding. If they are bleeding, they might need platelets instead of plasma. So we were in 2006, we were on 3 locations in Afghanistan. We had our own blood bank in the province of Uruzgan. We helped the Canadians with blood products in Kandahar. That's a very big hospital from Role 3, as we call it. And in Helmand, the English had a, or I should say British, had a facility in Helmand. So we helped each other, and also we treated each other's patients. When we were ongoing war, we just also still went for education. So we went to the ABB, and there we had the pleasure to listen to Dr. Hess and Dr. Holcomb, who told us about a total new approach at that time. And that was, of course, this was known to us, the lethal triad, the resuscitation, hemodilution, and then the resulting coagulopathy. But what they then continued to tell was that if they have this combination, you are absolutely sure you have a coagulopathic patient. So this is really detrimental if you have injury, shock, low temperature, and a low pH. And why is that? Well, platelets don't work at a cold temperature. So below 34, 40, the platelets don't work. So if you have platelets and they're circulating in a bleeding patient, they're not working. The effect of pH should also be known to doctors, but if you have a low pH, your thrombin generation will be got close to 0. So those elements are still important. But then this slide came. They looked back into the results and they show that if you use one red cell, for one plasma for every 8 red cells, you have a very high chance to die. And if you give more plasma, like 1 in 1.4 units, you will reduce your mortality. And if this wasn't convincing enough, they also show that the long-term survival was also improved if you give platelets. These were preliminary data they showed, and a few years later the full publication came, and that was a high platelet ratio and a low platelet ratio also show that if you in 24 hours or in days you have a higher chance of survival if you give more platelets to those patients. Also interestingly, they published that there was no difference with whole blood or apheresis platelets. They were just equally effective in reducing mortality rates. So this was the advice we took home. Use a 1-to-1-to-1 transfusion policy. In the meantime, it has been general knowledge, so maybe I'm telling you something you already know. 1 unit of plasma, 1 unit of red cells, and in this case, platelets are the American product, which is platelet-rich plasma. So if you have a pooled platelet from 5 donors, this would equal 1-to-1 would then equal 1-to-5, or 6 if you have apheresis platelets. So we took this message home, and immediately we started to train our clinicians that were ready to go to Afghanistan, that they should use a transfusion policy in massive bleeding patients, 4 red, 3 plasma, and 1 platelet, because there is a plasma already in the platelets. So this was our advice. We didn't push the product, we just advised first do 2 red, 2 plasma, and if it's still needed, go to 2 red, 1 plasma, and 1 platelet. And the funny thing, this is Camp Holland in Afghanistan. They really did do what we asked. And after that bloody war, we took all our data together, and I found Dr. Hoenkamp, and he had a trauma database, and I had a hemovigilance database, and we were able to combine our data after some judicial issues, and then we could publish on our results. We had 272 trauma patients in that 4-year period in this small hospital. This was only 10% of those all trauma patients that needed at least 1 red cell transfusion. Why did they need blood? Well, most patients were local patients. Some of them were from the Afghan National Army, but in fact, most were local nationals that came to our hospital for treatment. And as you see here, most of the patients were wounded by explosions or gunshot wounds. Here you see a little pattern of the patient frequency per month. And you see that there's actually unpredictable. That's what I wanted to show. In green, there are the non-massively transfused patients. And in black, the massively transfused patient. And in this case, we said that if you get more than 6 units in 20 or more than 5 units in 24 hours, we would call you a massively transfused patient. And if less, you call we non-massively transfused patient. And we studied then before and after the introduction of the transfusion policy. Here you see platelets and plasma on top of each other. And the red cells, you see here a peak of 120 units per month. But the rest of the time it was more quiet. We looked at the data and we saw that the patients were more heavily wounded after the introduction of the transfusion policy. both in the massively and in the non-massively transfused group. And after the introduction of the transfusion policy, we saw that our mortality decreased significantly at 24 hours, and in hospital, we went from 40% to 12% mortality in the massively transfused patient. But also in the non-massively transfused patients, we saw that although the length of stay was longer, that's probably because the more heavily wounded patients did survive this time, so they were helped for a longer time in the hospital. So we did not have a significant lowering of mortality, but who cares what is significant if it's your daughter or son that is on the table? So we were very happy to see that it worked, and also the surgeons were convinced it worked because they followed our advice. As you can see from this slide, they started to use more plasma and more platelets in both patient categories. So on average, a massively transfused patient received 12 red, 6 plasma, and 3 platelets, and a non-massively transfusion patient needed 3 red and 1 plasma, and every 2 patients need 1 platelet. So they listened to us and it helped. And it was a very nice thing to write down, as you can imagine. We use this number still to make an estimation how much blood we would need in the field based on patient expectations. So 10% of all the trauma patients needed blood, and only 30% was massively transfused and 70% non-massively transfused. So that helps us as a planning tool. And here you see that our ratios did increase. So in yellow, you see the plasma, in the squares, the non-massively transfused, and in the dots, the massively transfused, and we're getting close to 1. And with the platelets, we go getting close to 1 to 5. So 1 to 1 is never really reached, not always, usually because they already got 2 red before they thought about the massive transfusion protocol. We introduced thawed plasma by the end of the war, so we had it in the refrigerator, and when it was readily available, the doctors would also start using it earlier in treatment, and we also saw then a trend towards even lower mortality rates. So you cannot bring a freezer to special operation forces because they jump out of an airplane and then build their own little hospital. So we have then a cool box. And only what things we can put in there is plasma, thawed plasma, and red cells, and some fibrinogen. So this is the current situation, and they asked us, can you give us whole blood? But first, pre-hospital. We see this as a pre-hospital setting because it's only a very small location and with 1 surgeon and a few personnel to treat the patient further. So this is only for the first treatment and then ship them off to hospitals. And is pre-hospital transfusion a good idea? Well, I got a PhD student who looked at that in a meta-analysis and showed that red cells versus crystalloids didn't make a significant difference. But if you add the plasma to the mix, then you would get a significant reduction in mortality rates. So we think it is a good thing to have plasma also in the pre-hospital setting, and that's why we started to produce thawed plasma to give with the special forces. And then this lobby came. I don't know if you're familiar with this. Oh my God, my electricity is almost gone. How is that possible? The plug was not good in, so I hope I can continue. Yeah, we looked into that, and usually if I see a red cap like that, I become aggressive, and I think this is not the way, because that is what we used to do. But of course, it is easier to use if you only have a cold chain of transport and you have further no freezers or whatever, and you need to have platelets on location. So the platelets are in the whole blood, and you can store whole blood for 3 weeks. the platelets will go down in count in the bag, but at least there is some coagulation potential in there that's stronger than only plasma. But then I asked my new PhD student, Robert, to look into the meta-analysis for is it better than components? And then we found only a few studies that show that 24-hour mortality would be reduced, but non-significantly. 24-hour lower, so the first slide is the in-hospital mortality, late mortality. Oh yeah, sorry, I mixed up the slides, put some better glasses on. We looked into studies. I think somebody has his microphone open.
Sorry, I will see if I can find it.
I think it's
Just a
already
moment.
solved. Yes. So
You can continue. I will look for.
yes, I will continue. It's okay now. I don't hear anything anymore. Yeah, we looked into the studies that were published the last years, and we saw there were military studies and there were civilian studies. Well, in the military studies, they saw no difference in mortality rates, whether it was early 24-hour or late mortality. And if you then look at the civilian studies, most studies didn't see a significant difference. Only the studies of Heselton and Hanna, they did show a reduced mortality rate, and they used most of the patients in the study. So, but what you see is that in those patients, the ratios of platelet to red cells in the whole blood group was higher than in the control group. So we summarized those data, available data, and for the early mortality, we had 9 studies that really showed also the platelet to red cell ratio, plasma to red cell ratios, or we calculated it from the number of blood products they have used. And clearly it was that in all those studies, the whole blood group received more plasma and more platelets than the control group, just because there's also plasma and platelets in the whole blood. So we still think that whole blood and components are equally potent. It's just that you need to use the right ratio. If you use the right ratio, you won't find a significant difference in survival. So here you see the late mortality. There it doesn't make a difference at all. So it's still a question whether some people are still believing in the whole blood as a holy grail. I think it's complementary to the logistic chain, and you should only use it when you have not an option to use the components, because you don't have freezers or are not able to transport platelets in time to the location. So whole blood can be stored for 3 weeks, and the US has whole blood that can be stored for 5 weeks. But platelet in the whole blood, you should use the whole blood within 2 weeks, because then there's still platelet activity in the product. So how are we doing in the Netherlands when we came after our publication of our military data, where we started to do an inventory in all the level 1 trauma centers in the Netherlands on how they would use a massive transfusion protocol. In 2018, we started that study. And to our surprise, we saw that it was all over the map. Every hospital had its own little plan, and there were only a few that did it according to the new guidelines. And it was 331 in the Netherlands, because they have smaller plasma products with 200 ml. We use 431. And as you can see, if you calculate then the ratios, it would be 1:5 to 1:2. So it was, in our eyes, not consistent and not and surprising. And also, there's now a publication in 2022 where they studied massively transfused patients in the US trauma bases. And if you have that many patients, you can really do a nice study. Here you see the ratio in another way. So this is platelet-rich plasma, and 1:1 is then the norm. And you see that with every red cell, you give more to the in ratio to the platelets. So if you give 1 platelet every 6 units, of course you have a significant higher chance of mortality. So what they call unbalanced and non-balanced transfusion. The patients need both platelets and plasma. Platelets don't work without the plasma, and plasma doesn't work without the platelets. We know that from thrombocytopenic patients, they bleed. So they need platelets, they have plasma. And if you don't have coagulation factors, you probably start to bleed also, not spontaneously because you still have platelets, but if you have hemophilia, you might differ in your opinion. So we all know that you need all the components, and it was just getting back to basics to see that you needed uh, the right ratio of blood products. Well, it's a challenge for the blood bank, though. How can you provide all those products? So we also looked at literature for which ratio would be the best, and we scoped the literature, and again, Tim did all the work. 6-hour mortality, depending on the ratio comparison, the lower versus the higher the difference in mortality. And you see if you get close to 1:2 or 1:1, then it really doesn't make a difference in 24-hour mortality. When you look at long-term mortality, you just still see a significant difference. So this seems to be really working. We wanted to know that after that, we thought, okay, platelets are working, but is it now that our frozen platelets work better than liquid store platelets? Because frozen platelets are not the same as liquid store platelets. Frozen platelets are activated, and they are activated in such a way that they might not want to circulate, but they do want to stop the bleeding. To investigate that, we asked the Amsterdam Medical Center. They had a rat model up and running, and this is a traumatic bleeding model in the rat. So they do a lot of nasty things. I put in the small caps, and then that the rats bleed for an hour, or what was it for? It's there, 15 minutes uncontrolled bleeding, and then transfuse blood products until the blood pressure was back to 60 and measure how much blood was necessary. And we saw that we needed less platelets or less blood products to transfuse the rat and to come to this blood pressure again. So it was a pleasure to see that also after this 6 hours, the rats were sacrificed and there was looked at organ damage to see whether there was more thrombosis. We didn't see any evidence of that. So organ injury was similar. Clearly, the sites that were bleeding that stopped bleeding, and so the platelets did do their work. Here you see what is the cause of the activation is. The freezing is the cause, of course, but the reason they work hard is because there's a lot of microparticles in the product. So when I say I have a 75% recovery, this means that 25% of the platelets has been becoming too small to detect. And those are the microparticles because everything is still in the bag. So there's a lot of microparticles in the bag, and some analyzers also measure those microparticles as the bigger ones as a platelet. So that explains the differences between the two analyzers we saw. We also looked at the quality of our products in vitro in the thromboelastograph. I don't know if most of you might be familiar with that. It's a cup where you put the blood in, and there hangs a pin in the cup, and the cup is turning around, and as soon as you clot, then the pin will attach to the cup, and then you will measure the clot strength. or the time to clot. As you can see here in green, this is fresh platelets, the apheresis platelets. And you see that the frozen platelets are coagulating earlier and show a little less clot strength, but more than plasma. So we know the platelets still contribute to the coagulation, but the microparticles, and I don't know if I put the slide in, they are also equally fast as the, so if we, let's see if it's in there. No, not here. So if you centrifuge the frozen platelets and you take the supernatant, then you have the microparticles, and we see in TAG that they are equally fast as the frozen platelets, but have the same coagulation strength as the plasma. So the microparticles only contribute to clotting speed. Well, it's hard to enumerate microparticles because they are very small, but there's also a different test we started to use, and this is the phospholipid test. It's a test where you add activated factor 10 to phospholipid deficient plasma, and you measure the clotting time. You mix it then with your sample, and the faster the clotting time goes, the more microparticles or the more phospholipids are in there. In yellow, you see what the speed of a phospholipid-free plasma is. And in the green, this is the pure supernatant, and if you dilute it 250 times, you go and you have then a clotting time which is normal for plasma. So the supernatant of the platelets is 250 times stronger in thrombin generation than a normal plasma. And that is our explanation for the better work of stopping bleeding of the frozen platelets. Here you see in blue a fresh thawed platelet concentrate as a clotting time of 10 seconds. And the plasma has a clotting time of 60 seconds. So that's a huge difference. And fresh platelets have to show the same clotting time as the plasma. That's in light blue. And whole blood is even, fresh whole blood is even a little bit slower than that. When you store them in the cold, that was also of interest to us to look at the difference between cold stored platelets and frozen platelets. You see that they have more microparticles than the fresh ones, but still not the same as the frozen platelets. Also in whole blood, you see that the phospholipids are going up, so the clotting time becomes shorter. But and in plasma, if you store that at 14 degrees, 4 degrees for 14 days, you see that the phospholipids become less activated. They become inactivated by the plasma they are in. And here you see whole blood at 21 days, and it has the same, it's all supernatants, so they have the same amount of microparticles as 2 weeks stored platelets, whole blood. So I go very fast, I think, but in time, this is my final 3 slides. We are planning to do a clinical trial, and together with the hospital in Rotterdam, Academic Hospital Erasmus. Het Al Reine is the hospital where our senior surgeon works that promotes this study, Dr. Hoenkamp, and we're sponsored by the Dutch military healthcare insurance system. So we were lucky to find the funding, so now we can do a clinical trial. And we're still in the business of talking, we are not talking, they're talking to each other. All the lawyers are talking to each other who owns the data, and I hope we finally get an answer by the end of the year and can start the study. We published the protocol in 2022, and we already get a ethics committee approval in 2021. So we're really also a bit stressed by the COVID delays. So we hope to start then by the end of this year. Still optimistic, we keep on going. We trained the technicians in the lab, and what we used is colored fluids for the initial training. So they get a bag of yellow fluid and a bag of blue fluid, and they train how to mix those. And then when they do exam, then they have to make a real product. And here you see also on the left that you can have small -80 freezers. You don't need a huge thing for storage. So we have there the plasma and the platelets in the freezer, and they can prepare. So we trained 18 technicians in the lab. And by the time the clinical study trial will start, we will retrain them because it's too long ago. Usually we say our training course is only valid for 1 year because it's not something you do at home. So we want to see if everybody can do the job. So I hope I can answer some questions now and that I was clear and that you find a way to do it also, and I can teach you how to make them so we can collaborate. Thank you so much.
Great, thank you, Femke. That was absolutely fascinating.
Thank you.
So with that, I think we can take some questions. So Letzi is saying, amazing, this product could have a positive impact on patient blood management and improve patient outcomes. So yes, definitely.
Yes.
The use in South Africa, I think it, we never really considered providing this kind of product. But certainly there are certain, even in non-trauma use, certain situations where I thought of that we could use it. For example, when we have stem cell transplant patients who have HLA antibodies and need HLA matched platelets, and we only have one donor, but they'll need that platelet over a period of time. In my mind, I was thinking that one could collect, a couple of collections and freeze them. Should you then, so that you can have them available, because the 5-day shelf life wouldn't be sufficient.
Yes, I know that the use in thrombocytopenic patients has been proven to be non-inferior compared to liquid stored platelets. So it's definitely possible. We did it once for a Dutch patient who we couldn't find donors for, and Sanquin asked us if we could freeze her platelets autologous prior to her irradiation. We did that, and by the time we had 6 units in the freezer, the doctors could start initiate the therapy, and then they found 2 German donors for fresh platelets, so she could be treated all the way, and she only got one of her own products back, but it helps. What we know is that if you give the frozen platelets, the bleeding will stop. Your platelet count won't go up, or not really much, but if you look at the study by Larry Dumont and Cheryl Slichter, they did this study in the US. They showed that you need equal amounts of frozen products in the same rhythm. So you every 2 or 3 days you do the transfusion. So there was no difference in platelet use. So although you don't see the corrected count increment, the platelets do their job so good that yeah, the endothelial is repaired, and then you just can do the next transfusion 2 days later. And I just saw that Singapore has published their results in transfusion. I didn't read it yet. We trained them too to freeze platelets because they have the dengue season, so they have the problem of getting donors in time, so they can freeze out of season. Also in Poland, they use it a lot, frozen platelets, but that's liquid stored, liquid nitrogen frozen platelets. So yes, for thrombocytopenic patients, it can be used also very efficiently. Yes.
Okay, great, thanks. Prof. Johnny Maglangu's got his hand up. Prof, if you can, maybe while you're unmuting, there we go.
Absolutely.
Hi,
very, very exciting, and thanks for this very comprehensive cover of an area that I wasn't aware of. My question relates to the immunogenicity of the frozen platelets. Have you measured antibodies directed against the various components or the whole platelets in this setting?
I know that the HLA doesn't disappear from the platelets, so they're still platelets and they still have HLA. So, but there is nothing associated with the DMSO or the frozen platelets. We never heard of other transfusion reactions than those 2 urticarias we had. And also from other clinical trials, I didn't get the message that there would be a changed profile of proteins that would induce immunity. So we have
Yeah,
no.
I mean, I'm particularly interested in the normal course of managing ITP. We run into problems of antiplatelet antibodies directed against 2B3A.
Yes.
And I just wondered if that problem is solved by just freezing the platelets.
Well, the GP2B is still there. That's a good thing because it's a fibrinogen receptor. If they don't have it, then
Yep.
yeah. So I guess the frozen platelets would even be better to give because it will stop the bleeding if that's a problem with the ITP. And if you give more, then maybe you can tease out the antibodies. I don't know. We had one acute thrombocytopenic patient in the field, but that was probably by toxicity or something. It was a young guy, 19 years old, came into the doctor's room and he said, I don't know what happened. I woke up like this. I have bleeding nose, bleeding gums. I'm full of blue spots. I had a platelet count of 7. They decided to give him frozen platelets. That was the second patient we treated in 2002. And then the bleeding stopped immediately. So then they were able to transport the patient because then the pilot said, okay, if you hang another bag, I trusted that he's not going to bleed in the airplane. And he was transported out of the country because it was in Bosnia and then treated in an academic hospital to be cured again. So if the aim is to stop the bleeding, yes, it will work. Of course, it won't remove the antibodies forever. I don't know. There's other treatments to do that, I think, in ITP.
Thank you.
Or I'm not a specialist in that area.
Okay, thanks very much.
Thanks. Before we go to Marion, there's just 2 questions quickly that I think we can take. Are there any studies on the risk of thrombosis in non-trauma patients, like pregnant or stem cell transplant patients receiving frozen platelets?
There's
I would
no evidence
think
of
not, but
thrombosis. Frozen platelets have been used since the 70s, and there's no reports on this kind of adverse reactions. So I'm really confident that is not the case. Of course, trauma patients will become, after they have a bleeding phase, they'll have a thrombotic phase, but that's part of the injury and the repair of the reaction of the patient. So usually they are prophylaxically treated. But I know from all the clinical studies with frozen platelets in thrombocytopenia or other, no any thrombotic events. I do not know from pregnant women if there are clinical data available. If I think that stopping the bleeding is the first thing, and then there is thromboprophylaxis if to prevent in the later stage of patient treatment. At least, but I'm not a doctor. I don't treat people. I only see patients on paper.
thanks, Femke.
Yes.
Marion, you've got your hand up, Marion.
Yes, thanks, Femke. Very, very interesting webinar, and yeah, I thoroughly enjoyed it. A lot of information, so I probably missed quite a bit of it. But I wanted to just ask, and I probably missed this also at the very, very beginning, but how long after the collection of the platelets can it be frozen? We don't normally have platelets that expire. We never have enough platelets, but that's because we have very strict eligibility criteria. If those eligibility criteria were reduced, we could potentially make more pooled platelets. And I was just wondering, could you start like freezing them just before, if you see they're going to expire?
Yes, we
Thanks.
didn't do that ourselves. We freeze within 24 hours of donation because we don't have patients in the Netherlands. So every product we buy, we freeze. So we wanted to freeze as fresh as possible. Also because it was for us pioneering, and we didn't want to change the protocol I learned from Dr. Valeri in the US. But I know that Australia has looked into it. The Red Cross, Lacey Johnson and Denise Marks are really the investigators who looked at a lot of different things. And they showed that it's possible to freeze buffy coat platelets after 5 days. So this is definitely a possibility. Also, if you have Buffalo platelets or aqueous platelets in additive solution, it's not a problem. And in New Zealand, they freeze the Buffalo platelets, and they are doing now the CLIP trial in cardiopulmonary bypass because it's controllable, easier controllable to study than trauma. Of course, we want to study it in trauma because that's our main patient category. But I would also, in war, there's a lot of refugees that are pregnant and giving birth, so then it's also perfectly usable. If you have nothing, then frozen platelets are better than nothing. I'm very convinced that's the case.
Thank you. Thank you very much.
Okay, thanks. Then we have another question here from Ruseka Chakwe. Has this product been used in cardiac surgery, especially aneurysm surgery? And how have the results been if used?
I think they are only studied in clinical trials in cardiopulmonary bypass patients, not in aneurysm. I think aneurysm is a similar pattern as massive traumatic blood loss. Only the bleeding side is more controlled, but you need the transfusion of platelets and plasma. So I would use it also for aneurysm because it's a massive transfusion protocol. I think in any massive transfusion protocol it will fit.
Okay, and then there's one more. What is the best ratio for these blood products in case of massive transfusion? And Femke, maybe just to say that in South Africa, when we have Buffalo pooled platelets and
Yes.
apheresis platelets, and according to our standards of practice, the platelet count that we need to have is very similar to the products that you produce. So it's for us, it's 2.4 to 10 to the 11th. So very
Okay,
similar to
then
your
I would use
requirements.
the same thing, like 1 platelet in 4 red cells or 1 in 5 red cells. I think that would be perfect.
Yeah, we generally, so we use, so our pooled platelets, pooled platelets are generally preserved in platelet additive solution, and with the apheresis platelets are either in plasma or in
Yes.
platelet additive solution.
So
Yeah.
then if you have the platelets in additive solution, I would suggest you use a 4-4-1. So you add an extra plasma to the ratio because additive solution doesn't help coagulation.
Okay. I think I've covered all of the questions. If I have missed any, somebody just put up their hand. If not, I think just from my side, Femke, to say thank you so very much. Firstly, for coming to South Africa, to come and present at the PathRed Congress. And while when we saw that you were coming, both ourselves and the Western Cape Blood Service grabbed hold of Femke and asked her to do a couple of more presentations and also to come to the blood services to see how we do things, and maybe we can learn from her. So thank you very much for being willing to come out all the way to South Africa and for staying on longer.
Well,
And
thank you so much
very
for
much
inviting me. I had a
for
lovely time. I still
really
have.
interesting talk and great. Thank
I'm
you
really
very much.
honored
Thank
that
you,
you
everybody.
invited.
Have a great. Thanks, Femke. It was lovely having you. I think
Bye-bye.
with that, everybody, thank you very much. Enjoy the rest of your evening.
Thank you. Bye.
Bye-bye. See you
Thank
tomorrow.
you. Bye-bye.
Bye bye, Amal. Bye bye.
Bye-bye.